Okay, so this is a patient that I encountered in the burn unit. It's a 22-year-old male who presented to us from an outside hospital. Initially, his injury had occurred in Mexico, where he was apparently watering his lawn when he stepped on a live wire and sustained about a 75% TBSA combo electrical and flame burns. The initial injury took place on the 1st of April, and he arrived to us on the 4th. He'd been under resuscitated. His CK was 36,000 on arrival. And so we started our resuscitation with LR and titrated up to urine output. And he had arrived to us GCS 15. He didn't have a secure airway in place. He had been protecting his airway. Obviously, he had very significant burns that you see here. And so once we had kind of initiated resuscitation, we promptly intubated him and got him to the operating room. We did a very extensive operation, guillotine amputation of both his feet. He got 4 compartment fasciotomies and bilateral lower extremities. He got total fascial excisions of his thighs, and then he got some escharotomies elsewhere. So this is his admission chest x-ray, and he did okay in the OR. He got back to the ICU, his resuscitation continued, and on post-op day 1, he was doing all right, and he was doing well from a pulmonary standpoint. He had passed his SBT, and I was getting ready to extubate him. And so then this perfect storm of things happened where we had just done the SBT, so his sedation was a little bit light. His cuff was down because we had just done the SBT. And he got really agitated really quickly. He bit down on his ET tube. He had this large volume emesis and this massive aspiration event. 3 days later, his chest x-ray looked like this. And so we see multifocal consolidative opacity throughout both lungs, and these findings are suggestive of the diagnosis of ARDS. So what is ARDS? Defining ARDS in the literature is based on this PaO2 to FiO2 ratio, and this value serves as a surrogate measure of shunt. Because as we'll talk about more in a few slides, what we're truly talking about with ARDS is the creation of dead space. So an increase in this ventilation perfusion mismatch. If we wanted to truly measure shunt, we'd have to float a swan, measure mixed venous oxygen content, and then calculate the shunt fraction, which is obviously cumbersome, and we don't really float that many swans anymore, especially in our ICU. So this P to F ratio serves as a surrogate measure of hypoxemia. So at the American European Consensus Conference in '94, this P to F ratio was used to establish official definitions. And they had a definition for acute lung injury, which was a PaO2 to FiO2 ratio less than or equal to 300. And then within this umbrella of acute lung injury, there was a subset called ARDS, which was a P to F ratio of less than or equal to 200. In addition to these parameters, the AECC definition also called for a frontal chest x-ray displaying bilateral infiltrates, and it also called for a pulmonary artery wedge pressure to be less than or equal to 18 millimeters of mercury if it was measured. And this was in order to rule out hydrostatic pulmonary edema, or CHF, as the cause of respiratory failure. This definition was updated in 2012, and the update's known as the Berlin definition. It was more specific, and it defined what acute actually meant, so within 1 week of the clinical insult. And it also added that in order for patients to be diagnosed with ARDS, they should be ventilated to a PEEP of at least 5. This wasn't specified in the AECC definition, and it's in order to exclude patients who, in whom atelectasis could be the driver of their poor P to F ratio and their infiltrates. So the Berlin definition expanded to 3 different categories of ARDS: mild, moderate, and severe, based on the P to F ratio. And then it also expanded to include opacities identified on CT in addition to chest x-ray. The whole wedge pressure greater than or equal to 18 was removed from the definition and replaced with this rule that patients with ARDS should have some evidence that the heart failure isn't the cause of ARDS. So if we identify some other risk factor for this development of capillary leak and fluid buildup and fibrosis, then that's good enough to say, okay, this isn't heart failure, this is probably something else. And then for us, we can also use bedside echo to establish that it's not heart failure. So I think that we're all familiar with the pathophysiology of ARDS. There's some sort of inflammatory insult, and then with inflammation, there's swelling of the alveolar epithelium and the capillary endothelium. There's capillary leak leading to accumulation of interstitial fluid, and then there's protein leak. And then this inflammatory insult just propagates itself. There's release of more inflammatory mediators, activation of neutrophils and macrophages, hyaline membrane formation, and eventually fibrin deposition. And so this inflammatory process ultimately leads to pulmonary edema, which is, as we talked about, non-hydrostatic in nature. So it's not because of pulmonary hypertension pushing the fluid out of the capillaries. Instead, it's this massive leakage of fluid through the leaky capillaries, resulting in poor oxygen delivery. And thus we increase dead space. We create shunt. So we have these areas of the lungs where no matter how much oxygen you put into the airways, it's not able to reach the hemoglobin. So you get hypoxemia that's refractory to supplemental oxygen. And then you also get eventually fibrosis, which leads to loss of compliance. And so I think it's interesting to talk a little bit more about compliance, because I feel like when I used to think about ARDS, I used to think about this homogeneous loss of compliance where the whole lung just becomes like this big soggy sponge. But I think that management strategies, specifically proning, as well as ventilator-induced lung injury, makes a lot more sense when you think about the heterogeneous nature of the infiltrates, and also the different ways that forces act on different parts of the lung. And this became a lot clearer with the advent of CT, because you could really start to see how in different levels of the thorax, there are different degrees of disease. So I think the best way to think about this is to break the lung up into thinking about 3 different kinds of alveoli. And this is true really in normal lung too, because the way that normal forces act on the lung, there's always different levels of atelectasis in different parts of the lung. So we have the first type, which is the aerated alveoli. They're open, they're already participating in gas exchange. And then you have atelectatic alveoli, which are collapsed. And then within the atelectatic alveoli, some of them are recruitable. So they're collapsed, but maybe they could be converted into aerated alveoli if you could pop them open and keep them open with the right combination of driving pressure and PEEP. And we'll talk more about both of those things in a little bit. And so the point is that depending on where you are in the lung and what kind of atelectasis is happening, there's all different driving pressures that you need, because some of the alveoli are already open, so they don't need any really. And some of them are right next to all this area of fibrosis and stuff, so they might need a really big driving pressure to open them up. And some of them might be in like a normal-ish part of the lung and they're collapsed, but they don't need that much driving pressure to open them up. But of course, we can't select a driving pressure for each individual little bronchiole. And so we subject the whole lung to the same driving pressure, to the same kind of transpulmonary pressure. And so the alveoli that are already open are getting way too much, and the alveoli that are all stuck are not getting enough. And this is how we create even more injury in a lung that's already been subjected to a lot of injury. And so the aerated alveoli are exposed to higher pressures, and that causes volutrauma, which is overdistension of alveoli. That releases more inflammatory cytokines because of this new insult. And so that's referred to as biotrauma, that release of more cytokines. And then this volutrauma and biotrauma can lead the alveoli to burst. and then we get barotrauma, and that's when we get pneumothorax, pneumomediastinum, which are the words that I think we're all more used to working with. And so I make these distinctions because it's interesting that the compliance between one lung can vary so greatly. And so we're not talking about like one stiff lung. We're really talking about decreasing the size of the normal lung that we have to work with. So I bring up the example of a burn patient because it's a good surgery specific ARDS patient, and it drives home this point that the effects of extensive resuscitation and then aspiration can have obviously a big impact on the lungs. But there are obviously many more causes of ARDS, and these can be broken up into processes that cause direct injury to the lung and then processes that indirectly mess with the lung. So the direct ones include pneumonia, aspiration, non-protective ventilation, thoracic surgery, and then trauma. And the indirect ones include sepsis, and then other abdominal processes like pancreatitis, and then of course like multi-system organ failure and SIRS can lead to that cytokine release, etc. Okay, so now we can talk about treatment. I think everyone is probably familiar with ARDSnet, but just in case, we'll talk about it. It's a research network that was formed by the National Heart, Lung, and Blood Institute and the National Institutes of Health. And it was formed in order to carry out multi-center clinical trials of different ARDS treatments. And then based on these studies that were carried out, these guidelines were established. And so there were two big things that, based on the research, the ARDS network came out strongly in support of. And the first one was low tidal volume ventilation. And so low tidal volume ventilation is defined as like 4 to 8 cc's per kg of ideal body weight, and then a P-plat of less than 30 centimeters of water. And these recommendations came from several studies, the most prominent of which is ARMA, which was a multi-center RCT comparing traditional ventilation treatment, which was a tidal volume of 12 cc's per kg of predicted body weight with a goal plateau pressure of 50 or less. And that traditional treatment was compared to the low tidal volume group, where patients were started on mechanical ventilation with a tidal volume of 6 cc's per kg of predicted body weight. So that's important. If you're setting these people up with their vent settings, you want to use their predicted body weight. And so you would use their height, and there's like a chart you can look at that will tell you what 6 cc's per kg is based on that. And then a goal plateau pressure of 30 or less. And this study did show a mortality benefit for the low volume group, albeit it was a modest improvement, but it was a statistically significant mortality benefit. And this makes sense physiologically because smaller tidal volumes means less biotrauma, less inflammatory cytokine release, less inflammation, fibrosis, etc. So pretty much across the board, people agree that this is the way to go, low tidal volume ventilation. The next recommendation that ARDSnet came out strongly in favor of was proning. So the big trial in favor of proning is the PROCEVA trial, which was also an RCT. Patients in the prone group were prone for at least 16 hours of the day, and then they were flipped back supine for the rest of the day. The prone group had a 28-day mortality of 16% compared to 32.8% for the supine group. So it's interesting to talk a little bit about why we prone. And so we mentioned this a little bit when we were talking about the different forces acting on the lung in different parts. But what I think is interesting is thinking about how a lot of the atelectatic lung sits behind the heart and above the diaphragm. And so if you prone the patient and you take that weight of the heart off of the lungs, you allow that atelectatic lung to expand. You allow the chest to expand more symmetrically. You take the weight of that off the dorsum of the lungs and you allow them to inflate. And so proning is really just homogenizing the distribution of stress and strain within the lungs. And then you're reducing the overdistension of the aerated parts of the lung, and you're enhancing the recruitment of the parts that are all closed up. And so you're just improving the VQ mismatch. And so this study showed a 50% mortality reduction. So proning is really the thing that has been proven to be the most effective in reducing mortality from ARDS. And yet it's still kind of difficult to get people to do it, right? It's super labor intensive. It can be risky. In this study, the complications were quite low, but of course this study was carried out in hospitals that are used to proning, that have proning teams maybe, and so they're really good at it. So I see proning a lot here at Columbia now, but this is like an institution that really is very good at proning. So you can see at some outside hospitals, it can be difficult to get them to prone because they're scared, they're not used to it, afraid the ET tube will fall out, things like that. But I can't stress enough that this is the thing that has shown like the greatest mortality benefit. And so we should definitely be doing it. The third strong recommendation from ARDSnet is a hard no to high frequency oscillators. So these two studies are both multi-center RCTs that randomize patients with ARDS to high frequency oscillatory ventilation, or the control arm, which was standard low tidal volume ventilation with a high PEEP strategy. The Oscar trial showed no benefit to oscillators over traditional vents. The primary endpoint was 30-day mortality, and there was no significant difference. The Oscillate trial was actually stopped early because there was significantly higher mortality in the oscillator group. In addition, that group used more benzos, more paralytics, and more pressors than the control group. So definitely no high frequency oscillatory ventilation. The next recommendation is a conditional recommendation for use of high PEEP in patients with moderate to severe ARDS. So the data about PEEP isn't black and white. And there are a couple of different schools of thought on this. ARDSnet has like a low PEEP strategy that you can follow, and then a high PEEP strategy. And of course, the concept of PEEP is this open lung concept. So a proposal to use recruitment maneuvers and high PEEP to reduce ad-elect trauma. So the idea is to keep the alveoli open instead of having them consistently opening and closing, which is traumatic for them. So these are the trials that compared the high PEEP strategies and low PEEP strategies. So the alveoli trial had a high PEEP ladder with a mean of 13.2 was the PEEP versus a low PEEP ladder with a mean of 8.3. This trial was stopped early due to futility. The mortality rates in the two groups were almost exactly the same. The Loves trial, there was a high PEEP group with a mean of 14.6 and a low PEEP group with a mean of 9.8. This trial showed that there were lower rates of hypoxemia and lower rates of the use of rescue therapies, but the mortality between the groups was unchanged. And then the Express trial, there was a minimum distension group where PEEPs were 5 to 9, and then an increased recruitment groups where the PEEP was basically as high as possible without increasing the plateau pressures above 28 to 30. And this also did not show a mortality benefit, though it did show more vent-free days and more organ failure-free days. Now, if you combine all of this data, as this meta-analysis did, there actually is a statistically significant benefit in terms of in-hospital mortality for a higher PEEP strategy for patients with ARDS. So we have to specify that it's for patients with ARDS because all of these trials were conducted when we were still using that old definition. So we were still talking about acute lung injury versus ARDS. So if we kind of update the language a little bit, what this meta-analysis is telling us is that there probably is a mortality benefit for a higher PEEP strategy in patients with moderate to severe ARDS, and maybe not so much in patients with milder cases of ARDS. So I wanted to add a few slides about driving pressure, even though it's not specifically discussed in the ARDSnet recommendations that I was talking about. And it's relevant to what we were just talking about because the analysis here kind of questions whether the benefit that we see from high PEEP or even from low tidal volume ventilation is truly from those things, or is it actually because of how those things affect driving pressure? So what's driving pressure? It's easiest to think about driving pressure as your delta P. So it's the plateau pressure. So how much pressure the airways and the alveoli are seeing after you're able to let everything kind of settle out. So it's not that peak pressure. You have to do an inspiratory hold and wait for it to all equilibrate, and that's what your plateau pressure is. And then it's plateau pressure minus your PEEP, and that's your driving pressure. And really what it is it's sorry, I have to look at this. Oh, okay. And really what it is, it's a value of the function of your tidal volume as it relates to your compliance. So it's a ratio of your tidal volume to your respiratory system compliance. So obviously you can accomplish bigger tidal volumes with lower driving pressures if you have more compliant lungs. And so this trial used the data from 9 different randomized control trials to try to prove that it's actually driving pressure that matters far more than the other variables like PEEP or tidal volumes. So what they did was they looked at all of these subgroups. So for this first one here, they found a bunch of people from these studies who had similar mean PEEPs, but different driving pressures. And then another group of people here that had similar driving pressures, but all different PEEPs. And the third group with different PEEPs and different driving pressures. And what they found was there was an association between increased driving pressure and increased mortality. If the driving pressure remained constant, even if the PEEP went up, this didn't affect mortality. And then here, when you had a decrease in your driving pressure, even with that increase in PEEP, you had a decrease, or with that increase in PEEP, you had a decrease in your mortality. So this could explain why some of those studies of the higher PEEP trials weren't able to reach significance, because maybe it's actually the driving pressure that's the more important factor and not so much the PEEP. Sorry, I know I'm running out of time. Getting back to the ARDS-NET recommendations, there's some recommendations about fluid balance. We all know that dry lungs are happy lungs. Obviously, if you have a critically ill patient who is like in shock, you need to resuscitate them. But this FACT trial, which compared a conservative versus a liberal strategy of fluid management, the liberal group had a mean fluid balance of about +7 liters. Conservative group was approximately net even. No clear mortality benefit, but the net even group did have better oxygenation, more vent-free days, more ICU-free days, and they didn't have a higher incidence of shock or dialysis. So probably good to try to restrict fluid when you can. In terms of recruitment maneuvers, ARDS-NET made a conditional recommendation. I don't have any papers about recruitment maneuvers, but we touched on earlier the open lung strategy. So the idea of trying to open up the lung, keep it open. There are different ways that you can do this. What I've seen here is basically just turning the PEEP up really high for a little bit of time and then coming back down. The key being coming back down to a higher PEEP than it was when you started. And so some people will do that here to try to recruit some lung, if maybe, especially if you think that, you were just on the transport vent and maybe you de-recruited a little bit, but it's kind of physician dependent whether or not people actually do it. And then I have a little slide about APRV. ARDS-NET didn't formally comment on the use of APRV or airway pressure release ventilation, but I think it's cool. We don't get too much exposure to it, I don't think. There's definitely varying levels of comfort level among staff and among, RT. But with this mode of ventilation, the idea is to give high continuous positive pressure. So that's your P high. So that would be here, your P high for a long time. That's your T high. And then followed by a drop in pressure to P low for a shorter duration, which is your T low. So you set all of those values, the idea being to maximize alveolar recruitment and limiting the amount of deflating that the lung can do. So just going along with that open lung strategy. The key to APRV is that spontaneous breathing is able to happen here and here. So you really don't want to do this in a patient that's paralyzed, because it kind of depends on that variation kind of on top of that PEEP, allowing the patient to breathe on top of it. In terms of neuromuscular blockade, ARDSNet also didn't comment on this. They deferred discussion about paralysis. The goal of paralysis is to maximize synchrony with the vent. So this could also be achieved by deepening sedation. And obviously you want to have a patient really deep before you move to paralyzing them. But basically the idea is if you paralyze them, you're making sure that they're not fighting the vent at all, and you're getting all of the possible compliance that their lungs have to offer. This is the Accuresis study, which compared treatment with neural blocking agent cis atracurium for 48 hours early in the course of severe ARDS with people who were not paralyzed. And they saw an improved 90-day survival rate, increased the amount of vent-free days and days outside of the ICU. It did not, however, improve overall 90-day mortality. So that's why ARDSNet didn't really, I guess, choose to comment on it, because we don't really see the mortality benefit. However, I think that, as we already stated, the role of paralysis is really to increase vent synchrony used in patients with, with hypoxemia that isn't getting better with your other roles. And then in any treatment strategy that it's built into. So for example, proning, a lot of centers that have like, this is how we prone people will have paralysis as part of that algorithm, or in, optimizing your patient before they go on ECMO, paralyzing will be a part of that protocol. So I'm out of time before we get to talk about the fun stuff, which is ECMO, but we're going to talk about this stuff tomorrow, and we'll talk about these two trials, and I'm sure Dr. Nisset will cover them extensively.
Okay. Sorry, you can keep going if you like. Dr. Fletcher had a question, but he had to step out. But that was a great talk. We will touch on mostly Eolia tomorrow. We can let folks ask any questions they have. Otherwise, that's probably the best synopsis about ARDS and the evidence related to how we manage it that you guys are going to hear, especially in 30 minutes. So we can open it up for questions, or Meg, if you're busy, I'm sure you have someone to go cannulate.